how can you treat kidney cancer? Unfortunately, despite all the advances in genetics and chemotherapy and radiotherapy and all these other modalities, the kidney cancer is not sensitive to radiotherapy and is not sensitive to standard chemotherapy. And the most effective way of curing, of treating kidney cancer, is to take it out of the body. It's a very simple, crude solution to a complex problem, but that is the most definite way of getting rid of kidney cancer. You either have to take it out or you can destroy it. You can destroy it by freezing it or heating it up. If the cancer is still only within the kidney and you take it all away, then the chances of cure is excellent. If the cancer is spread to distant organs like the lungs or the bones, then we can't cure it with surgery. We can improve things with surgery, but then we are in a containment situation where we treat with different treatments that I'll get to a bit later. So to remove the cancer from the body, we either need to remove the whole kidney, or if it's a small tumor and it's well placed, we can sometimes remove part of the kidney, or we can freeze or burn a small tumor. Big tumors like this massive mass over here, the only way of removing that is to remove the whole kidney with a big open operation, either through the level of the lowest rib or perhaps through the front or in the middle. And this is still what we use for big renal tumors to this day. In 1990, however, an American by the name of Ralph Kleiman did the first laparoscopic keyhole surgery. He used the technology that the general surgeons are just starting to use to take out gallbladders. Took out the first kidney laparoscopically 15 years ago. And since then there's been a massive expansion in laparoscopic urology surgery. And what we do is we place a camera inside. We make 3 or 4 small incisions in the body, either through the abdomen or from behind, below the level of the lowest rib. We put a camera inside, we put 2 or 3 instruments in, and we do what we would do with open surgery, but without having our hands inside. It means tiny incisions, very precise dissection, and we can, for the vast majority of cases, we can do exactly what we used to do with open surgery, with keyhole surgery. And most total kidney removal operations now are performed with keyhole surgery rather than with open surgery. During the last 10 to 15 years, in the same period when there's been this big expansion of keyhole surgery removing kidneys, there's also been an increased awareness that we can actually, for appropriate cases, remove only part of the kidney, that you don't always have to remove the whole kidney. If a tumor is small in the right place, you can just remove that part of the kidney with an equivalent cancer outcome, an equivalent cure to removing the whole kidney. In addition, with more and more people having scans, having imaging for various reasons, more and more small kidney tumors are detected. Incidentally, people might have no symptoms, but their scan shows there's a 2 or 3 centimeter mass in the kidney. We also have become more and more aware that whilst a person can live perfectly well on one kidney, if you do have a low level of renal impairment, of kidney impairment, even not to the degree that you would need dialysis or anything like that, that is not very good for you. In the long term, your risk of cardiovascular complications like heart attacks and strokes go up quite a bit if your kidney function is less than normal. So whilst you can live perfectly well on one kidney, especially if you have hypertension or diabetes or something else that is already affecting your overall kidney function, 1.5 or 1 3/4 kidney probably better than 1 if possible. With laparoscopic, with keyhole surgery, there are many advantages to the patient: smaller incisions, less blood loss, less pain, less analgesic requirements, quicker recovery, less complications from those big scars with the open surgery. Obese patients, which is an increasing problem, doesn't really pose a problem for laparoscopic surgery because we have a camera inside. We don't have to put our hands inside the body. So for those patients who need their whole kidney removed, if it is not a massive big tumor that we can't do with keyhole surgery, laparoscopic total kidney removal is an excellent excellent choice. It's predictable, it's safe, it's very well performed in the UK. But many patients now present with an incidentally detected small renal mass. And here the dilemma is, do we do a fairly straightforward laparoscopic keyhole total kidney removal, or do we just remove part of the kidney? Removing part of the kidney is technically a much more demanding and difficult operation than removing the whole of the kidney. When you remove the whole kidney, you disconnect its blood supply in total, and you take it all out. The kidney, however, has a massive amount of blood flowing through it. So if you want to or need to take just part of the kidney away, there are quite a few steps that you need to do. You need to control the blood flow into the kidney, then cut away the abnormal part, and then repair the defect. The problem with that is that the kidney needs oxygen like any other organ, and it can only tolerate not having blood flow for about 20 minutes at most. So you are a bit under the clock. You can increase the time that you can clamp the artery by cooling the kidney down with ice. And this is easier done with an open operation than with a keyhole operation. If you do remove small renal masses, then we find that about half are either benign, 25% turn out to be those benign masses, and many are cancers with low metastatic potential, the lower risk kidney cancers, and perhaps half or slightly more are the renal cell carcinomas. These are for small renal masses, 2 centimeters, that sort of size. So you can see that you don't really want to lose your whole kidney for something that might end up being not cancer or not a very risky cancer. There you can see clamping of the blood vessels. This bit is going to be removed and then stitched back together. This is an open operation with ice slush packed around the kidney. So you could ask, why don't we do partial nephrectomy all the time? It's because the complication rate is higher. There's a much higher risk of bleeding. There's a higher risk of urine leaking from the kidney, and it is technically difficult to do with keyhole surgery. Many patients don't withstand big, massive open surgery very well. There are some potential solutions. This you might have heard of more in terms of prostate cancer. This is a machine called the Vinci Robot. It's not really a robot. It's a master slave, where the surgeon sits in a console like this, controlling this machine. It's the next version of laparoscopic of keyhole surgery, and instead of controlling the instruments directly through holes in the body, these instruments are rested inside the body, and the surgeon can perform all the movements that we would do outside with open surgery. We also get a very good three-dimensional view. Standard keyhole surgery, laparoscopic surgery, uses one camera, one lens, so it's like you are operating with one eye closed. Your brain compensates for that. Why we can see depth is because we have two eyes. The robotic camera has two cameras in the same telescope, and gives you in that console a true 3D picture. The instruments are rested on the inside, and the surgeon controls this two little handles, and when you do the surgery, you feel as if you are in the patient doing the operation like you would with open surgery. You don't realize that you are actually driving a machine that's a few yards away from you. Most radical prostatectomy, so the operation for removing the prostate for cancer in this country and in America, are now performed with this machine. That's standard laparoscopic instruments. These are the robotic instruments, and you can see they can rest like that. If you have to do complex suturing, like you need to do with taking part of the kidney out, then this is an advance. It's emerging as an alternative to standard laparoscopic partial nephrectomy and open nephrectomy. And you could probably do slightly more complex cases that you could do with standard keyhole surgery. But as you can imagine, it's very expensive. So in London, there are several of these machines. There's the Marsden Hospital at St. George's, Guy's, the Imperial Group, some of the private hospitals in central London. This is about £2 million worth of equipment, and all those instruments are very, very expensive. One company has the patent on the whole thing that they're controlling pretty tightly. But with this type of technology, it tends to get better over time, and it tends to get cheaper. So I suspect that this will not go away. When we take a whole kidney out, we don't really need that robot machine to help us to do that. But when we need to do a complex reconstruction, removing a small part of the kidney, this looks like a very viable alternative that will probably increase rather than decrease in usage. But do you have to always take the cancer out? Remember, many of the small cancers are incidentally detected, and many we know grow very, very slowly, if at all. In the past, our pathology, our histopathology, the people who look at samples under the microscope, have been apprehensive about being able to give us a clear answer on a small biopsy taken with a needle from a kidney mass. So the perceived wisdom until perhaps 5-10 years ago is that it's very difficult to be certain on a biopsy from a kidney what you're dealing with. I'm pleased to say that that is improving dramatically. We are making more and more use of biopsy for the small renal mass. Just remember, if you can prove that it's benign, you could perhaps leave it alone or just monitor it. If people are perhaps not very fit or much older, then surveillance is also a very realistic option. There are many patients who we watch with small renal masses that never grow or grow so slowly that they are never going to run into any trouble, and we only treat the ones where we believe there is a risk of that mass doing harm to the patient. In a kidney mass under 3 or perhaps under 2 centimeters, we really never see spread to any other organs. If a small tumor is not growing, it's much less likely to spread. And even the ones who grow by millimeters over months. It's not generally a rapidly growing thing. What about ablation? We can destroy kidney cancer cells by freezing or heating. Freezing is called cryotherapy. And this can be delivered in a very minimally invasive way now, where our radiology colleagues uses a CT scan to identify exactly where the tumor is, and then under an anesthetic, but without cutting the patient open, a needle or needles are placed under screening guidance into the tumor, and the tumor is then frozen, and that kills and destroys the tumor cells. It's not suitable for big tumors, but for small tumors under 3 centimeters, preferably 2 centimeters, and in an appropriate position, it's not as good as removing, but it's almost as good with much less morbidity and risk. The local recurrence rate, in other words, the chances of the cancer growing back in the kidney after freezing, is 12%, which is significantly higher than if you've taken it out. But if you are perhaps a bit older and you've got a lot of comorbidity, that's a chance you might take. We can also repeat ablation if we need to. Cryotherapy, freezing is slightly more popular than heating with radiofrequency ablation, but both of these modalities are readily available and used. The mass is still there. It's not being removed. It shrivels up, and this is what we see on. This is CT scans again. That's a right kidney. This is the left kidney. This is a tumor there at 4 weeks, 3 months, and 9 months, sort of shriveling away, having been treated with cryotherapy. We can freeze it. We can also heat it. Radiofrequency uses electricity basically to produce heat. So in general, freezing or heating works well for small tumors. They need to be in an appropriate position. Not all tumors are in a position where one can get a needle to them safely. It's much less invasive, but the cure rates are not as high as removal. The best cure is either removing the kidney or part of the kidney. So what we really need, we need better biopsies, and that is happening more and more, so that we can make a more informed decision in terms of treatment, especially for the small renal tumor. For the larger tumors, it is less important for us to have a biopsy where we know from the scan really what we are dealing with. I think the role of robotic partial nephrectomy for small renal tumors will increase, and ablation is a very attractive option for the appropriate patients. So I think our current practice for smaller tumors is to perform a partial nephrectomy if appropriate, to remember that we can survey patients. For larger tumors or tumors in the middle of the kidney, we remove the whole kidney, and where possible we do that with keyhole surgery, with laparoscopic surgery. We don't really need the Vinci Robot to remove the whole kidney. For very large tumors, tumors where the lymph nodes are involved, tumors that have grown into the big veins of the kidney or the vena cava, we still perform conventional open surgery as we have done for years. What about if the cancer is spread? So if the cancer is only in the kidney and we can take it all out, our chance of cure are excellent. Once it is spread, it's a whole different ball game. If we have high volume disease in the kidney and only a small amount of disease outside of the kidney, then we still go and take the kidney out. We make that decision in conjunction with our oncology colleagues. If you take the main bulk of disease away, the patients tend to do better, providing they are fit enough to withstand the surgery, and sometimes you get shrinkage of the sites away from the kidney. If however there is widespread metastatic disease, then the treatment usually is first by the oncologist with what we call systemic therapy. This is not chemotherapy in the conventional sense of the word. These are all oral tablet-based treatments. There are several of them on the market now. Kidney cancer classically, typically generates a large amount of new blood vessel formation. It's called angiogenesis, and most of these treatments work on blocking the processes that control that new blood vessel formation within the cancer and the metastatic sites. Unfortunately, at the moment, there is no cure for people with kidney cancer that is spread widely to other parts of the body. Many of these treatments can control disease for many years, and there is a big range of response. Some people respond much better than others. I suspect in the future there will be much more individualized treatment where we would look more carefully at the exact genetics of the specific cancer and target the specific treatment. At the moment, it's not a one size fits all, but we don't yet understand enough about every specific patient's individual cancer as to why it would respond to a certain drug or not, why that cancer would spread or not. Interestingly enough, if you have kidney cancer and you have spread, but it's only one site or two sites away from the kidney, then there is sometimes a role for going to take those sites out. And what we would do in that situation is we take the kidney, the primary tumor out, and then we give a period of time. We monitor, let's say there's a spot in the lung, and if in 6 months or a year or 18 months it still is only one spot in the lung, then there is sometimes a role for further surgery by the chest surgeons to go and take that bit of cancer away as well. In terms of prognosis, small kidney cancers, the prognosis is excellent. Cancers confined to the kidney, even slightly larger, the prognosis again is excellent. Once you have invasion into the fat around the kidney, into the lymph nodes, into the adjacent structures, even if you remove all of that, the risk of recurrence, the risk of having disease crop up somewhere else, the risk of dying from kidney cancer is much higher. Thank you.